And hello, welcome everyone back to Generally Practicing. It is Thursday night. Thursday night, of course, means practice night. My name's Kane Treble. I'm a GP based out of Mildura, far northwest Victoria, and I am here tonight to help you practice for the 2024.2 KFP exam. If you've been joining us so far, we've had the last couple of weeks dedicated to the CCE exam, but of course, tonight we are getting back to KFP practice. We'll start off with a bit of teaching, then go through 3 sample cases, each with 3 independent questions, run through. The more you put in, the more hopefully we can get out from this. So if you want to participate tonight, put your answers in the chat. We can go through why they might be good, why they might be needing some improvement. The more you practice, the more you pretend like it's on the day, the better you're going to do long term. Okay, so good to see we have some familiar people in the chat, but of course, let's get through to some teaching. So we are 37 days to the 2024.2 KFP exam. We still have time to get some kind of last-minute practice, last-minute study in, but of course this is really about refining your technique from this point. You shouldn't be trying to learn whole new topics, rather consolidate what you know, find those areas of weaknesses, and do what you can to try and strengthen those at this point. I want you to focus in on avoiding repetition. A really common mistake, and something that I think as well, if you haven't gotten onto it already, this is the time to start to focus in on this. Try not to repeat any information that's already provided in the STEM. Avoid mentioning things like smoking cessation and the management options if the patient's smoking status hasn't actually been indicated. This is a way of showing that you have put your contextual knowledge of management of these kinds of patients to the patient sitting in front of you. If the patient's not mentioned to be a smoker, it's not something you would necessarily presume, and they're trying to give you the information relevant to the case in the STEM. So all the information you need to make your answers should be there. It's a really important thing to try and remember. Now, of course, for history taking, for questions around a patient's symptoms, focus on new or relevant details that may specifically answer the question being asked. Again, a common thing. Make sure you're answering the question being asked. And make sure as well, as part of that diversifying your answers, try not to use the same response for multiple questions in the same case. If you're finding that is something you have fallen into, look where that answer might be most appropriate and use that opportunity then to redirect one of those answers towards a different area. Now, if you're struggling to actually fill in and find those answers, there are those fallbacks to kind of lean back on so that you can hopefully regain as many marks. And really, a lot of it comes back to reading the qualifier of the question. Now, for diagnosis, I want you to really focus in on what is the potential acute diagnosis, what is the subacute diagnosis, what is the chronic diagnosis. Usually, if you try and apply that kind of framework, you're going to be able to tease out usually 3 responses that may be applicable to that question. On the acute side, don't forget your DRS A, B, C, D, E. Think through each, for the presentation, each of those different aspects and try and see if that will actually tease out a management option for you. If you have a surgical patient or a patient that's potentially going to need surgery, a free, easy mark is don't forget to fast the patient. Make them kneel by mouth so that you have the best chance possible of securing a mark there. And of course, the old thing of don't ever forget the glucose. A really, really important thing is to monitor, to check glucose or supplement glucose as required. For your chronic management options, some fallbacks will be, if we're looking with pharmacological, don't forget oxygen is technically a drug. It is a thing that is administered and so falls under that pharmacological management. Of course, the medication, in previous years, you've had to know dosing and dosing regimes, no longer applicable. And so doses are not specifically required unless they are specifically requested. The key things for dosing you're going to need to know will be things like your adrenaline, your 0.5 mics, the things that you need to know in an emergency. So focus in on those kinds of things. Try not to get too bogged up in all the other individual doses for every medication. There's a change and a reflection that it's clinicians marking this. They appreciate that you're going to be checking AMH, you're going to be checking ETG to confirm the doses you're using in real life are actually applicable. Don't forget your immunisations as well. Know what could be applicable to the case sitting in front of you, bearing in mind that answer can and will change if it's an Aboriginal or Torres Strait Islander patient who have a separate immunisation schedule. And I get it. I get it. It's so frustrating having to memorise immunisation schedules because we don't do it in clinical practice day to day. It is something that we would look up at the time. It changes all the time. It's adapted to the information base, but it is something for the exam you are expected to know. And of course, for your management, particularly of those chronic conditions, always remember your care plans and your health assessments can be pivotal in securing a long-term management plan. So focusing in on those is going to be easy marks. Now, for your non-pharmacological management, this is an area that some people really struggle with. Use those frameworks. Use things like SNAPs, smoking, nutrition, alcohol, physical activity. Don't forget to throw in a physiotherapist for a dedicated exercise regime. Bearing in mind, anytime you're mentioning any of these kinds of things, specify why you're doing it as well. So physiotherapist for, occupational therapist for home modification or activity modifications, psychologist for CBT or DBT or any appropriate therapy, dietitian for meal planning, weight loss regime as applicable. And your condition-specific kind of support services, whether it's an online support group, whether it's a group that are known to be active in this space, things like Cancer Australia, make sure you're using those extra supports. And of course, for legal advice, patient always goes to lawyer, doctor goes to medical indemnity. Don't forget as well, housing and living assistance, looking at those social determinants are really, really important in the exam. And so exploring what kind of assistance may be available in that spot. And of course, the RACGP handybook. If you do not know this handbook, you are throwing away marks. I can tell you now, there's always a couple of questions in every single exam that rely heavily on even passing knowledge of the handy handbook on how to approach that question. But of course, we have some practice questions for everyone to practice today. We have 3 cases, each with 3 questions. Let's start off. Let's put 3 minutes on the clock. 2 minutes and your time starts now. Hannah Lee, a 45-year-old woman, presents to your GP clinic with a 2-month history of fatigue, weight loss and joint pain. She reports experiencing intermittent fevers and night sweats. Over the past few weeks, she's noticed a rash on her legs, which she describes as red and purplish spots. Hannah has a past medical history of hypertension, for which she takes amlodipine 5 mg daily. She has no known allergies, does not smoke, and drinks occasional alcohol. On examination, Hannah appears pale and slightly unwell. Her vital signs are temperature 37.8 degrees, blood pressure of 140/85, heart rate of 88 beats per minute, respiratory rate of 16 breaths per minute, and oxygen saturation of 97% in room air. You note a palpable pruritic rash on her lower legs and mild tenderness in her joints. Question 1.1. What differential diagnoses should be considered based on Hannah's presentation? List 4 differential diagnoses. All right, and time is up. Let's get to some of those answers then. And this is one of those questions there where it can be so many things. So feel free to kind of shoot from the hip and throw out pretty much anything you can think of, because it's probably going to be worth some marks. So the big ticket items, of course, you should be thinking with a presentation like this is going to be an acute vasculitis, and in this case, a Henoch-Schönlein purpura. That's going to give you 3 marks. This could also be, and equal to consider would be, acute infective endocarditis, particularly with that purpuric rash. Now, there is that kind of chronic nature, those night sweats there. This could also be something like myeloma, so it would be high on the list. And even though we have had this medication as a long-term medication, you can have drug eruption rashes at any time. So another thing you would have to consider. Kind of tying in with the leukemia, and I suspect in reality would probably be grouped together, would be leukemia. And of course, systemic lupus erythematosus, one of the great mimics that can present as just about anything. Rheumatoid arthritis, and this would be a slightly more atypical presentation, particularly with that rash, but something you would have to consider. And then some of your kind of less likely, but things you would kind of keep in the back of the head: deep vein thrombosis, sarcoidosis, tuberculosis, polycythemia vera, and a hemolytic anemia, being rather non-specific, so certainly worth less points here. I think if you're showing that you're thinking along these kinds of trains of thought, you're going to be getting marks. And really, this is one of those questions that have so many potential answers. But you can see there's that weighting there towards those ones that show that consultant level finesse. And of course, coming in from the chat here, we've got systemic lupus, fantastic, meningococcosemia. Now, I'm going to be a little bit picky on this one because, yes, if you're looking at that from the acute setting, but this is specifying this has been occurring over the last few weeks. And so if it was something like meningococcal septicemia, this would be a patient that would probably be doing much, much worse, much, much sooner. And so I don't think you would actually get as many marks from that one. Rheumatic fever, yep, definitely, and kind of ties into a lot of these same eruptions there, and drug reaction as you've specified. So very well done on those answers there. Now, of course, we've got more questions to get through. So let's get 2 minutes on the clock, and your time starts now. Question 1.2. What initial investigations would help to further evaluate Hannah's condition? Write 5 specific investigations. All right, time is up. Let's have a look at those answers there. Now, I originally tried to write this one as a multiple choice, but there are so many things you can throw out. So again, thought I'd switch it over and turn it to a response. One of the things, particularly with this time frame, you would be considering would be a tissue biopsy of the lesion. This is going to give you lots of information about the underlying etiology. So that would be very high on the list and worth lots of marks. Of course, you've got your full blood count. You'd be looking at both your platelets, given the nature of the rash, as well as your inflammatory markers, so white cell count, and your red blood cells as well, checking for any evidence of anemia. You're also going to be looking at your ESR, your erythrocyte sedimentation rate, which is going to give you lots of information about the inflammatory state of the body. This is one of those times where your anchor, your anti-neutrophil cytoplasmic antibodies will come into play. Your C-reactive protein is, again, inflammatory status. Your complement protein, C3, C4, anti-nuclear antibodies. I know. Occasionally we have to actually order that for good reasons. It's one of those tricky ones that will come up all the time, and it's always borderline. Anyway, rheumatoid factor as well, cryoglobulins, coagulation studies, and throat swab looking for streptococci or streptococcal antibody titers, as long as you're kind of acknowledging that at risk of streptococcus being the initiating factor. Hepatitis B or C serology, human immunodeficiency virus serology, remembering seroconversion syndrome can do all kinds of weird and wonderful things, and your serum protein electrophoresis or urine protein electrophoresis, again looking for your hematological malignancies. Blood cultures, if we are thinking this could be along that kind of septicemia type picture, and of course, or infective endocarditis, sorry, and your urinalysis or urine microscopy culture sensitivities or looking for cast cells. So heaps and heaps of things that you can be throwing out here. This is kind of that looking at your vasculitic screen, your inflammatory screen, your infective endocarditis screen, and malignancy screen as well. Coming in from the chat, we've got FBE, LFT, blood film, which is not on here, but certainly would be part of that full blood examination. If they're actually doing a proper full blood examination, it should be someone looking on a film, but yes, excellent to actually specify that. Coagulation studies, absolutely fantastic, and TFTs. Now, I don't have TFTs on this list, but you are 100% correct. That would definitely be worth marks there, remembering thyroid disease can present with all kinds of weird, wonderful things, one of the great mimics, and so would be applicable here. Well done. And of course here we've got another one, FBC, ESR, ANA, Anchor, blood film. All fantastic answers there. Well done. Now, I'm going to be super picky, and again, I know you guys know, I know, but spell stuff out. Try not to use the abbreviations, because remember, there's no guarantee that on the exam day, the college or the examiners will actually accept any of those abbreviations. And so if, similar to what, say, Demir's put in here, where essentially it's all the abbreviations, you may have actually just thrown away all the marks except for blood film. It's pedantic, I know. It's frustrating because sometimes we don't know how to spell all these long words, and that's okay as well. They've said, you know, if the spelling's incorrect, that's okay, as long as they can get across what it was you were trying to order, that is fine. So do practice from today, actually spelling everything out. It's frustrating, I know. All right, we have a third question on this case. So let's get 2 minutes on the clock, and your time starts now. Question 1.3. What are potential serious complications of untreated vasculitis? Write 4 specific complications. All right, time is up. Let's have a look at some answers here. So heaps of complications, and of course, these are things that you should be pretty familiar with. So of course, one of the big ones is acute renal failure, pulmonary hemorrhage, myocardial infarction, gastrointestinal perforation, skin ulceration, stroke. All of those things are going to get you 2 marks. They're the big things we really, really worry about. Of course, there's also things like peripheral neuropathy, aneurysm formation, vision loss or blindness, as well as chronic pain and disability. These are things that are certainly important, can have a dramatic impact on a patient's life, but they're not that same immediate life-threateningness, and so would be worth 1 mark. Now, I want to point out as well here that this is one of those times where they actually give away late in the case part of what this diagnosis could be. And this is one of those times as well, if you've been struggling to kind of work out what's going on, this is where reading through the exam first and kind of getting a feel for what each case is about can be really, really helpful. Because if you hadn't picked up that this was a vasculitis, here is your answer sitting in front of you. And so you can actually go back and put that in and make sure that you're getting as many marks as possible. Now, of course, coming into the chat here, we've got from Demir, permanent vision loss, perfect, renal failure, definitely, ischemic heart disease, yes, definitely, and stroke, fantastic, full marks there, well done. And here as well, we've got liver failure, kidney failure, thrombosis, definitely, and myocardial infarction, definitely. Now, I would be a little bit careful, you may get grouping there for thrombosis and myocardial infarction, because myocardial infarction may be part of that thrombosis picture. So similar etiology. I mean, you can have multiple things contribute to a myocardial infarction in the setting of a vasculitis. Wow, try saying that 10 times fast. So I would just try and diversify those answers ever so slightly, just again to make sure you get the best chance of getting as many marks as possible. But all very good things to be keeping in mind, so well done. All right, now of course, let's get on to the next case then. So case number 2. Oh, and of course I want to acknowledge for that last case there. Thank you, DermNet. And if you're not someone who actually goes through and has a look through the DermNet photos, again, given we don't have that much time before the exam, now is actually a really good time to do it. Keep them fresh in your mind because most of the derm or skin kind of questions are going to come from DermNet. There is a fantastic library on DermNet that you can actually just step through, have a look at the pictures, have a quick read of the condition that's involved. They have fantastic summary articles that if you are time poor, you can just kind of have a read through and just try and get a feel for a couple of the big kind of ticket areas and just read up, refresh your knowledge. Okay, so a comment in here from the chat as well, not a topic I know much about, and yeah, this is one of those cases that I think it's easy to miss in your kind of internship HMO years. A lot of medical schools don't have vasculitis as a kind of significant R1 topic if you've gone through the Monash model, and so it's one of those things that I think if you haven't actually seen a patient with it, this one could be one of those cases you don't do as well in. Which is again why we do these practices here to try and identify areas that you may need to do a bit of reading up on. And so if it's something you're not feeling that very confident in, do a quick read up. DermNet, the College of Pathology, and RACGP, if you just do Google for RACGP vasculitis, you're going to find a heap of really good articles written for the GP knowledge base. Let's get 2 minutes on the clock for your next question. 2 minutes and your time starts now. Isabella Harrington, a 28-year-old woman of English descent, presents to your GP clinic with complaints of persistent fatigue and dizziness for the past 3 months. She mentions having unusual cravings for non-food substances such as chalk, paper and ice. She denies any chest pain, shortness of breath, palpitations or weight loss. She doesn't smoke, drink alcohol or use recreational drugs. Isabella works as an accountant and lives alone. On examination, Isabella appears pale and tired. Her vital signs include a temperature of 36.8 degrees, blood pressure of 110/70, a pulse of 88, and a respiratory rate of 16, with a BMI of 22.5. Her cardiovascular, respiratory, and abdominal examinations are unremarkable. Question 2.1. What additional aspects of history are important to elicit to confirm Isabella's most likely diagnosis? Write 5 specific aspects of history. All right, time is up. Let's have a look at those answers. So, additional aspects that haven't been covered here is going to be what are her dietary habits or what's her nutritional intake? Are there other aspects of her diet that we need to be exploring as well? Is there any personal history of anemia or iron deficiency or blood disorders? Now, again, you wouldn't be having slashes in these kinds of answers. These will all be things that be tied up together. Is there any previous history of picker? Is there any previous developmental history, anything that occurred to her during childhood? Any history of gastrointestinal symptoms? Now, that's intentionally quite vague. I think if you were to put some examples in there, that would kind of hone into that same thing, and there'd be grouping associated with that. What is her sexual activity history or pregnancy history? Is there any chance she may in fact be pregnant? What is her menstrual history as well? Does she have any psychological or psychiatric history? This is a bit of an unusual behaviour you'd be wanting to explore. And is there any exposure history or environmental history, in particular lead exposure potential? We'll talk a bit more about that coming up. Is there any other detailed history of cravings? And again, providing potential things such as the duration of these cravings, the intensity. She's already mentioned some of these substances there, so to be honest, I don't think you would actually get additional marks for that. But again, kind of clarifying some of those cravings there would be worth additional marks. And tying into this as well would be the family history of anemia or iron deficiency or other blood disorders. Coming in from the chat here, we've got Melina, excellent, so coming into those GI kind of symptoms, menorrhagia, so part of that menstrual history, pruritus ani, yes, I know what you're getting at there. I would be saying again, potentially diversify with the Melina. You're ticking the box for the GI things, and there's other things you could potentially explore. Having said that, with what you're getting at, you might still get a half mark there. Vegetarian diet, so yep, you're looking at nutrients going in, and use of pantoprazole, fantastic, again, exploring that absorption ability, or is it something impairing the absorption, so well done. Also coming in from chat, we have dietary intake of iron, fantastic. It's almost like you guys know what's going on here. Oh, menorrhagia, again, yes, tying into the periods there, past history of iron deficiency, well done, and family history of bleeding disorders. Guys, you are knocking it out of the park. Okay. I'm going to have to make harder questions, I think. Of course, what could be going on? It's a mystery. So let's get 2 minutes on the clock and your time starts now. Question 2.2. What initial investigations would be important to investigate this condition? Write 3 specific investigations. All right, time is up. Let's have a look at some answers here. So some of the big ticket items I really want you to be focusing in on here is going to be your full blood count and your serum iron studies. Because as you've certainly picked up already, this is a case of picker. And one of the leading causes of pica is iron deficiency, and in particular iron deficiency anemia. So you'd be needing to confirm that with your FBE and your iron studies there. Now, of course, with all these things ingested, it's common to have electrolyte imbalance or organ damage, so you'd be wanting to keep an eye on urea and electrolytes, keep an eye on the kidney function. Tying into that, what's causing potential absorption issues here, you would consider doing celiac serology, and of course serum calcium or magnesium or phosphate levels, again using those absorption markers to see is there issues in terms of the bowel's ability to absorb nutrients there. And serum lead concentration. So in houses that have lead paint or potential for lead to be around the place, it's actually quite common, sadly, for people with pica to be ingesting things that contain lead without realising it. And so there's a strong recommendation for people with these cravings for non-food items to have this assessed, particularly if they are in older type houses, because it is something that can cause profound morbidity. So one of those things you're just strongly encouraged to screen for. Let's have a look at what's coming from chat here. So we've got full blood count. Yep, fantastic. Again, I'm going to be mean. Spell it out. I know I'm being nitpicky. Iron studies, fantastic. And ultrasound pelvis. Don't know if you get marks for that one, but I think if you're worried about bleeding or not sure. Always good to throw something out, and I'd rather you throw something in than leave a potential spot blank. Coming in from Jenna here, we've got the FBE, fantastic, iron studies, fantastic, and celiac serology, fantastic. So knocking it out of the park, well done. All right, we have one final question on this case. So let's get 2 minutes on the clock, and your time starts now. Question 2.3. What is your management for Isabella's condition? Provide 5 management options. Doses are not required. Investigations return to show a serum iron of 30 mics per deciliter, normal range of 60 to 170, a serum ferritin of 8 with a normal range of 15 to 150, a total iron binding capacity of 450 with a normal range of 240 to 450, a transferrin of 360 with a normal range of 200 to 350, and a transferrin saturation of 6% with a normal range of 20 to 50%. Other results are all within normal ranges. All right, time is up. Let's have a look at some answers here. So, management options here. Obviously, we have a case of iron deficiency, and so we'd be commencing an iron supplementation. I think the numbers here aren't horrific. You could consider an oral solution here, or tablet, or solution. Of course, given the severity of symptoms here with the abnormal eating pattern, I think it'd be pretty fair game to be considering an infusion here, even though it doesn't specify the anemia component. I think given the impact and potential harm of the symptoms ongoing, an iron infusion would be pretty appropriate. Of course, you're going to discourage the eating of non-food items. You're going to monitor for sources of blood loss in case there is a bleeding pattern that's been masked for some time. You're going to be considering a referral to a psychologist for things like cognitive behavioural therapy to explore and potentially change the eating patterns. It may be the anemia is a bit of a red herring, particularly given there's no evidence of, the iron deficiency is a red herring, given there's no evidence of anemia there. Because this can be a psychiatric condition as well, so referral to a psychiatrist for diagnostic assessment could also be considered. Now, of course, we've addressed that there could be issues with the absorption, and we know that there is low iron. We'd be potentially referring to a dietitian for a dietary review or modification plan to make sure she's actually getting adequate dietary iron, and a plan to review iron stores in 6 weeks' time. Here's one of those times as well you could actually provide written information on picker/iron deficiency covering those things. It's kind of one of those vague management options there. It would be really a kind of last-ditch effort. I would be definitely prioritising these other issues here. So, having a look through what's coming in from the chat here, we've got iron infusion, i.e. Ferinject, fantastic. Oral iron supplementation, i.e. Ferrograd C. I don't know if I'd be doing both simultaneously. I'd probably list one or the other. You're probably going to get some grouping issues there. Increased dietary intake of iron. Again, yes, I think that would be good. You're addressing it from the dietary point of view, but you're probably going to be grouping there with referral to dietitian to optimize iron intake. From Tamir here, we've got the Ferinject, fantastic. Multifer, again, kind of fits into that same kind of supplementation risk. 1 steak per day, dietary, fantastic. No milk with iron-rich foods. Oh, man, massive, massive, massive. And while that is a dietary thing, I think there is a chance you probably would actually get a mark for that, given its specific dietary advice. Maybe not. I think it's probably a little bit risky. Likewise, referral to dietitian for dietary intervention kind of falls in that same category. So trying to diversify answers, I'd just be a little bit careful. Comment here, CBT, give me a break, man. Yeah, I know. You may think what a load of, but this could be a psychological condition, and so actually addressing it to redirect those cravings is actually a valid and used tool in this space. So, sorry, gets you marks, and is something that some patients do find very, very helpful. All right. We have a whole new case, a chance to reset, refresh our minds, something perhaps a little bit fun, a little bit wild to head out with tonight. So let's get 2 minutes on the clock and your time starts now. Dean Centre, a 28-year-old male presents to your GP urgent care clinic complaining of a fishing accident occurring 20 minutes prior. It seems during casting, a friend of his flicked the rod back, catching Dean's right thumb at the level of the interphalangeal joint. On examination, Dean appears comfortable. A photo of his injury is included below, showing a hook embedded into the interphalangeal joint of the right thumb. Question 3.1. What is aspects of investigation that might hint at a more serious injury? Provide 5 specific examination findings. All right, time is up. Let's have a look at those answers. So, This is one of those cases that sometimes life throws you inspiration. This was something I saw the other day in general practice, and I thought, you know what, probably make a good KFP question. So, of course, the key things we look at when we see these kinds of wounds is really about that neurovascular injury. So, evidence of vascular injury or decreased perfusion to the distal digit will get you a mark there. Evidence of a nerve injury / decreased sensation to distal digit will get you a mark. Of course, you wouldn't be phrasing it like that. You'd be specifying one or the other, or you risk overcoding. Evidence of tendon injury, or in this case, it's on the back of the thumb there, so you'd be saying inability to extend the thumb. Evidence of fracture / avulsion / bony tenderness, anything that's going to underlie bony or joint injury there. And, of course, obviously, contaminated wound. All things going to get you good marks. Coming in from the chat here, we have exit wound. I'm not sure if exit wound per se would hint at a more serious injury. Visibly dirty wounds certainly will, though. Numbness at the fingertip, again, perfect. Looking at the nerve injury side of things. Visible first DRPJ penetration. Yep, so again, you're kind of getting into that joint involvement or bony involvement. And impaired first distal phalanx active extension. Fantastic, again, going into that tendon injury. Well done. Also in from the chat, we have inability to flex interphalangeal joint, fantastic. Decreased temperature of distal phalanx, good. So that's picking up on the perfusion or vascular injury side of things. Decreased sensation in distal phalanx, fantastic. And too slow for the 2 minutes. That's right. We run out of time from time to time. I think you've hit a lot of nails on heads there. I think you've done very well. All right. So we've got this issue. What are we going to do about it? Let's put 2 minutes on the clock, and your time starts now. Question 3.2. You assess there is no significant injury. Dean asks for assistance in removing the hook. Provide 5 management steps for hook removal. All right, time is up. Let's have a look at the answers. So, always think back to what are the individual step-by-step things you're going to be doing, as silly as you may feel at the time. So, of course, you're going to clean the site. You're going to be using a claw hex or appropriate skin preparation to clean the skin. Mark. You're going to anaesthetise the digit using local anaesthesia, and you can specify ring block. Perfect. Get your mark. You're going to remove the hook using a back out technique or advance and cut technique or a string yank technique. If you're not familiar with those, we'll go through in a second. Thought I'd take the opportunity to share, and that's going to be 2 marks there because it's actually addressing the issue of removing the hook. You're going to then irrigate the wound. If you have a potentially contaminated wound, irrigation is an important step to make sure that any potential foreign bodies can be irrigated and flushed out. You're then going to dress the wound with an appropriate wound dressing. You're going to repeat the physical assessment after the hook has been removed to see if any further injury has occurred during removal. and you're going to organise a wound review in 24 to 48 hours given the risk of infection in this space. Coming in from the chat here, we've got perform ring block, fantastic. Wash out wound, fantastic. Slowly remove the hook, fantastic. Use gauze to control bleeding, and dress wound. You may get into overcoating there, or I'd probably diversify a little bit more between the use gauze to control bleeding and dress wound, but otherwise, excellent answers there. Prepare a sterile field, not on here, but yes, definitely, and would get your mark as well. Hand hygiene, again, yes, would get your mark. Wash off visible dirt, so again, cleaning the skin. Instill a ring block for thumb, fantastic. And remove nail with clean technique, remove hook with clean technique. Yes, I think you would probably get 1 mark if you're not specifying it as a technique for it. And you don't have to use these exact words. I think as long as you're describing kind of roughly what you're doing. But just saying you're removing it, probably worth less marks, sorry. So for those that don't know, the back out technique is literally as it sounds, following the path of the wound itself. Only good if you have a very superficial injury, because you're going to traumatize the tract that the hook is in, because you essentially have that barb cutting tissue along the way. Of course, we have some other options here. This is the push technique, where you actually push the hook through the skin to actually get that barb back out again. You cut the hook so that you no longer have that barb there, and then you can very easily, very safely remove the hook back out from the original track there as well. I'm not as necessarily big a fan of this technique, particularly around joints, given the potential to actually cause more injury. But for, again, relatively superficial ones, can be a get out of jail card for you, particularly if you're not feeling as confident on using other techniques. Now, the string yank technique, and this is the technique I personally prefer, is actually using physics to your advantage. If you use, I normally use suture material or just some kind of string and actually tie that around the hook itself. As you can see kind of up on the screen, you can tie that to the loop section of it, and if you place pressure down on the eye, the kind of longer part of the hook, you actually angle that barb, you're pushing it down, so releasing it from the tissue, at which point a quick sharp yank on the hook will often bring it out of the tissue with minimal, if any, further trauma. Incredibly effective, works really well. Relatively quick as well, which the patients often quite prefer, and I like that you're not then causing another hole, another potential source of infection to come in here. Okay, let's have a look at the chat here. So here we've got a comment, old mate would have yanked that out himself 10 seconds after the accident in real life. You know what? Nah, not always. Particularly those people who are particularly needle phobic, and I've had patients that, or people who have seen the hook in and fainted and passed out, and ambulances have been called, they've been brought into ED, things like that. So a lot of fishermen probably won't be too concerned. This is one of those things, if you've been a fisherman for long enough, you've seen this undoubtedly. But yep, as happened to me the other day, people come to the GP for stuff like this all the time. These are the little things I absolutely love. Excellent. Now, we still have one more question, so let's get to that one. Let's put 2 minutes on the clock, and your time starts now. Question 3.3. You ask about Dean's last tetanus vaccination, and he admits he can't recall receiving any. He asks if this is something he should worry about. You discuss tetanus-prone wounds. Provide 4 specific risk factors for tetanus-prone wounds. right, time is up. Let's have a look at the answers here. And these are, of course, taken directly from the Australian Immunisation Handbook. And these are things we should know about when are we actually going to be giving a tetanus immunisation. Now, compound fractures. If you have a bone-breaking skin, that's going to put you at increased risk of tetanus infection, so you're going to give a tetanus booster if due. Bite wounds, any deep or penetrating wounds, any wounds that contain foreign bodies or foreign material, wounds that are complicated by pyogenic infections, wounds with extensive tissue damage, and that's example here is your contusions, so think motorbike abrasions or burns, and any superficial wound that is obviously contaminated. Any reimplantation of an evolved tooth also qualifies, and depot injections for people who inject drugs also require tetanus boosters. Having a look in the chat here, we've got animal bites, fantastic, open fractures, fantastic, wounds contaminated with soil, definitely, and penetrating wounds, I hear this hook, well done. Coming in here, we've got a immunocompromised host. While that would increase the risk of the likelihood of you giving a tetanus booster, again, read the question being asked, provide 4 specific risk factors for tetanus-prone wounds. I don't know if that would necessarily get your mark. Potentially, but I would say I'd probably try and go by some of the other answers here. Visibly dirty, penetrating object, excellent. You've kind of covered 2 different things there, so I'd try and flesh those out to visibly dirty or contaminated and penetrating wound. Not up to date with vaccination. Again, going back to the question, risk factors for tetanus-prone wounds, probably wouldn't get a mark there, but you still picked up a couple of marks there, so I think you would still get through on that one there. All right, and that's the last one for tonight. Well done. Thanks for sticking in there. Thanks for being with me still at 9:20 on a Thursday night. Greatly appreciated. And again, I still hope you guys are finding this helpful, and I'm still keen to keep doing these live streams as well. So for the next 2 weeks, I will actually be thinking of going back, or I will be going back to the CCE question, just because we're about to hit the CCE exam. But then after those next 2 weeks, I'll be coming back and continuing on with KFP questions as well. So hopefully you find it all useful. Of course, you guys here tonight are going to do just fine on the KFP exam. I think you're showing you've done the study, you're thinking the right way. Couple of those little answering techniques, again, just polishing up, but I'm sure on the actual exam day, you're not going to fall for any of those traps. So keep up that excellent work. I can see you're really putting a lot of effort in. Of course, you probably want to go to bed, I imagine. Where else would you rather be? So I will leave you guys to it for tonight then. If there's no other comments or questions in the chat, I'll, as usual, hang around for a minute or 2 after the stream ends just to see if anything does come through. I'm keen to get feedback in any way, shape or form, so leave comments in there and I'll get to them over the next week as well. Without further ado, have a lovely evening, guys. Keep up the excellent work and remember to keep generally practicing. That's such a lame way to end it. Sorry.